Very good. Would you like me to start?
I guess you should give the permission, like the host Professor Donna,
yes.
to have the access to the
Yes,
I will make
sharing the
permission
screen.
for recording, yes.
Yes, I will make you a host, Professor Donna. I forgot.
Oh, so I can
Yes,
share.
you can
Okay.
share your screen now. And thank you so much for being available to stay with us today. We are so glad. Thank you so much.
Well, it is my pleasure. Let's see, I will make sure I can share my slides. There we go.
Oh, great.
Can see, yes, well, good morning, everyone. Thank you for joining. Bom dia, I remember from my visit to Brazil. And I really would like to thank Professor Lais for inviting me to present to your research group about the nursing care of patients who are managing fecal incontinence conservatively. I'm very happy to connect with my Brazilian colleagues again about common interests that we have. So as you know, fecal incontinence is a life-altering chronic condition that is associated with stigma and emotional distress. It interferes with daily life activities and lowers quality of life. Fecal incontinence management requires ongoing self-management by the patient. It's optimally guided by a plan from a healthcare provider such as a nurse, and that's what we're going to focus on in this presentation today. And research, as well as our practice experience, has shown that patients improve with conservative management. And so I'd like to provide some practical context to this presentation by starting with a case study. This is a case of a 42-year-old single male, we'll call him Mr. A, who has fecal incontinence after surgery for hemorrhoids. From his health history, we learn he leaks loose and liquid feces a few days per week and has some liquid stools. He has not really paid attention to when or why he leaks liquid stools and when they occur. He does not use absorbent pads or briefs and says he doesn't really know much about them. He doesn't know about trigger foods. He is not on any special diet, but his diet seems low in dietary fiber from his description of what he eats. He drinks several cups of regular coffee per day and has a beer every 2 to 3 days after work with his friends. His work is sedentary because he's a software programmer, so he does not get much exercise. His physical exam shows no additional hemorrhoids or prolapse, but he has a weak external anal sphincter contraction. He sometimes takes an antacid for stomach ache stress, as he calls it, related to his job. And I'm going to come back to this case study near the end of my presentation with a management plan after we discuss some of the options. So knowing the possible etiologies of fecal incontinence can assist in understanding a patient's health history and possible associations with fecal incontinence and guide a management plan. Many patients do not understand how or why fecal incontinence might develop and will benefit from patient teaching. So fecal incontinence is associated with several disease and chronic conditions, such as trauma to the nerves or muscles of the pelvic floor or anal sphincter from injury or after surgery, systemic neurological or muscular problems, such as from a stroke, multiple sclerosis, and even diabetes, problems that prevent complete closure of the anal sphincter, such as a hemorrhoid or prolapsed rectum that continue after surgery, the weakness that might occur, and inflammatory bowel diseases or cancers. Other factors that can result in fecal incontinence are weak pelvic floor muscles, such as after childbirth, Having stress urinary continence is also a risk for fecal incontinence, and both may be related to weak pelvic floor muscles. Having liquid or loose consistency of stools. Cognitive problems such as dementia, where someone is unable to perform even the steps of the toileting process. And mobility and functional limitations that reduce the ability for independent toileting. There can be more than one factor involved, especially if the patient has comorbidities. And unfortunately, sometimes the cause is not always known. So the nursing care for patients with fecal incontinence focuses on supporting their self-management using conservative interventions initially. This includes developing a plan of care with the patient, using conservative interventions which are recommended, engaging the patient in their self-management by building their skills and confidence in self-management, monitoring their progress over time, problem solving, and revising the plan of care as needed. So on this slide, I outlined the initial interventions that nurses have in their practice toolkit for conservative nursing management of patients with fecal incontinence. These include patient and sometimes caregiver education, especially if the patient is older, use of a bowel diary, various diet modification strategies, medications, rectal emptying, trying to achieve a regular bowel elimination pattern, and strengthening coping and practical skills. There is a recent randomized controlled trial whose results show that educating patients about fecal incontinence and conservative management can reduce fecal incontinence symptoms significantly. The study compared 4 conservative interventions, including patient education, anti-motility medications, and pelvic floor muscle training using biofeedback. Results showed no significant difference among the groups. All groups showed improvement. So these findings support results of earlier studies showing similar outcome and the effectiveness of conservative management. So one of the key assessment tools for clinicians, as well as a guide for an intervention plan, is a bowel diary. Research has shown that keeping a bowel diary can also assist patients understand their bowel patterns of both continent, stools, and incontinence episodes, and raise awareness of their symptoms. Reporting on a bowel diary helps the patient with self-monitoring their activities. It can help reveal some associations, such as leakage after eating certain trigger foods or drinks. And it can be used to monitor effectiveness of interventions over time. So patients are recommended to record on a bowel diary for at least 7 consecutive days. This would include a weekend when diet and activity often change on non-work days. I was on an international working group of the International Continence Society that identified 14 short standard questions to ask on a bowel diary. The questions ask about the characteristics of the leakage as well as the continence stools. So those questions are about the type of leakage. Does it occur with a bowel movement or in between? The frequency, the day and time, the consistency, again, of both the leak and the bowel movement, an estimated amount, it's not an exact amount, whether there was flatus and awareness of the leakage, and whether the patient took any anti-diarrheal medications or wears an absorbent pad. There is a fill-in-the-blank question where the patient can record information such as, did the leakage happen during exercise or some other activity, or was it associated with pain or other symptoms? So here you see the standard questions laid out in a one-page format. Most questions are in a checklist format, which the consensus group determined was user-friendly. And the questions were developed to be suitable to include in an online or a mobile diary. Now, this diary is available for use through the ICS and also can be translated into Portuguese. And I know there are plans to do so from the ICS in several languages. So conservative interventions for fecal incontinence also include modifying dietary intake. This approach is primarily aimed at reducing fecal incontinence frequency and loose liquid consistency of stools and leaks. And there are several approaches to diet modification. Many individuals report worsening of their fecal incontinence symptoms after eating certain types of foods or drink, and we refer to these as trigger foods. Teaching the patient to identify and avoid these trigger foods that either result in incontinence or worsen their symptoms may result in improvement. Pairing completion of a bowel diary with a diet record is a way to identify these trigger foods. There are no results from a randomized controlled trial on diet interventions, but there is evidence from several descriptive studies using several different patient groups that reports similar types of trigger foods that worsen fecal incontinence symptoms. And these foods include foods that are very spicy, like peppery spicy, fatty, greasy foods, eggs, caffeinated drinks, dairy products such as milk, some fruit such as citrus fruits, apricots, strawberries, nuts, seeds, and popcorn that has shells. Foods known to increase flatus, such as onions, beans, cabbage, and broccoli, and also alcohol, especially beer. Now, some patients do not want to give up their favorite foods completely, but if they are aware of what these trigger foods are, they can plan perhaps for some of the symptoms that they will after eating for it and better manage them. Now, some patients may benefit from a diet containing foods high in dietary fiber. Most people in the US do not eat the daily recommended amount of dietary fiber, which is 25 grams per day, and their diets are fairly low in dietary fiber. So they can try and increase the foods that are high in fiber. Other patients may need the opposite approach. Those who have irritable bowel or an inflamed bowel may need a low residue diet. This is a diet that contains foods low in fiber or contain fiber that is highly fermented without leaving much residue behind. Additionally, checking if the patient has an intolerance to lactose or gluten is important because avoiding these foods may help lessen their symptoms. A diet low in FODMAPs was observed to reduce fecal incontinence severity. FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are short-chain carbohydrates or sugars that the small intestine absorbs poorly. So foods high in FODMAPs are listed on this slide and are foods such as Brussels sprouts, cauliflower, mushrooms, beans, garlic, cow's milk. And if you recognize, some of these are foods that produce flatus, and also on that list of trigger foods that other studies have identified. So reducing the intake of FODMAPs may also reduce fecal incontinence symptoms. So sometimes it's difficult for a person to eat enough food to achieve a high fiber diet, especially if they are elderly and maybe their intake is not so great. So that is when taking a fiber supplement can help. There are a couple of randomized controlled trials showing good evidence that supplements of dietary fiber, in particular psyllium fiber, can significantly reduce fecal incontinence. The amount of fiber to start with and all that may be needed may be small, such as 3 to 6 grams per day, but higher amounts can be taken and tolerated. And, when eating a diet high in fiber or taking a fiber supplement can cause some GI symptoms in some individuals initially, but they usually subside and they're usually small and tolerated. But just as with other symptoms such as pain, this is very much an individual matter, the tolerance. It's also important to remind the person to take extra fluid when taking a fiber supplement. If psyllium does not work for the patient, there are other types of fiber supplements that can be tried. One study showed that a methylcellulose supplement reduced fecal incontinence and improved stool consistency. And there are many types of fiber supplements that are available over the counter that the patient can purchase, and they come in various forms. Powders that can be mixed in water or juices, tablets that they can take, and even cookies or biscuits. So you wonder, well, how can dietary fiber improve fecal incontinence? Some people think of dietary fiber as an intervention for constipation. Well, there are several possible mechanisms that might be at play. A couple of studies, including ours, showed that the unfermented fiber that occurs with psyllium, for example, that remains in the intestine, in the large intestine, forms a gel with fecal water. And this helps reduce the liquidity of stool and the frequency of leakage. Another mechanism may be that the unfermented fiber increases the water holding capacity of the solids that remain in the stool. Fermentation of dietary fiber by the bacteria in the colon provides energy substrates to the cells of the colon and improves their function and health, and also increases water absorption. So there may be more than one mechanism that is operating. So there is the question of whether weight loss reduces fecal incontinence. Observational studies, mostly in women, show mixed results about an association of being overweight or obese and fecal incontinence. And we know that weight loss can reduce symptoms of urinary incontinence, but similar findings have not been reported for fecal incontinence, either from studies of dieting programs or after bariatric surgery. So there is no current recommendation for weight loss to reduce fecal incontinence, but for patients who are obese, weight loss is recommended for general health, so this might be a recommendation, or if the patient has both urinary and fecal incontinence, that this might be part of the plan. Likewise, moderate physical activity has been associated with a lower risk of fecal incontinence. Again, there haven't been any studies showing that general exercise is an effective treatment for fecal incontinence, but it has general health benefits, and so exercise can be recommended for the general health of the patient. Medications for fecal incontinence depend on the cause. The medication most often used for fecal incontinence frequency or liquid stools is loperamide. This is an anti-motility or anti-diarrheal medication. There have been several studies showing the effectiveness of loperamide. Here you see the starting dose is about 2 grams. before each meal and at bedtime, and this can be increased to 4 grams per day at those times. Some patients only take this medication on an as-needed basis, perhaps if they are going out in public or they have a special event, more so than taking it on a regular schedule. A second medication is cholestyramine, and this would be used if the patient is having some bile acid malabsorption. Cholestyramine is an anion-exchange resin and a bile acid binder. If the patient is having bowel spasms, such as from inflammatory bowel disease, then medications such as dicyclamine, which help relax the intestinal muscles, might be prescribed, and which may help result in decreased leakage. Now, there are some medications that are not used to treat fecal incontinence, but whose side effects may result in fecal incontinence. So doing a medication review of the patient is recommended. There are drugs such as stool softeners, laxatives, orlistat, magnesium-containing antacids that are taken for other reasons that might have a side effect of loose stools that increase leakage. Antibiotics, short-term, may cause loose stools and diarrhea. There are medications that relax the anal sphincter, calcium channel agonists, beta blockers. And there are also drugs that reduce alertness and responsiveness to the urge for defecation or slow mobility, such as antidepressants and antipsychotics. Now, these medications are given for a reason and cannot be discontinued in most cases, but perhaps another type or class of medication may have fewer side effects than some others, and it is worth a review. Pelvic floor muscle training, which some patients refer to as Kegel exercises, are now recommended as an initial treatment for fecal incontinence. Past studies have shown mixed results, but more recent studies have shown better results. And it's been shown that these are low-risk interventions and are now recommended as part of initial conservative strategies. They do require motivation and practice and functioning motor and sensory nerves. So for fecal incontinence, pelvic floor muscle training involves exercises to strengthen the muscles of the pelvic floor as well as of the external anal sphincter. And these muscles are under voluntary control. And the exercises would consist of contracting and relaxing those muscles and progressively increasing the number of repetitions, say up to 10%, the duration of the contractions, and performing them in different positions, such as sitting, standing, and lying down. And we encourage patients to do these along with their other activities of daily living so that they actually perform them, waiting in the line at the grocery store or lying in bed after they awaken but are not ready to get out of bed, to help make them as part of their usual routine. So promoting complete elimination of the contents of the rectum is a way to reduce leakage if it occurs in between bowel movements. Some patients complain of this feeling of incomplete evacuation. So teaching the patient to have the proper defecation position can be helpful to fully empty the rectum of feces. So the recommended position is for the patient to lean slightly forward, keeping their back straight, and to raise the knees higher than the hips. This can be done using a stool or some other type of footrest. To steady themselves, the patient may place their elbows or hands on their upper legs or use grab bars if they have them. What this position does is to create a more acute angle so that the feces can more easily leave the rectum. Here you see in a sitting position, it's more of a right angle, where this position here facilitates elimination. The position also helps release the hold of this muscle around the neck of the rectum. You see it results in a more relaxed position of that muscle that enables more complete elimination. Now, another approach is to clear the rectum of feces so that there is nothing remaining to leak. Some of these approaches include abdominal massage, taking a suppository. Some patients say that taking senna or prunes is effective, or digital stimulation. There's also the use of transanal irrigation. This involves installation of water into the bowel and allowing it to drain out of the rectum using gravity. This intervention was initially tried and shown to be effective in those individuals who have neurogenic fecal incontinence, such as from spinal cord injury. But we know that, especially out of your reports, that there are patients who are using this technique, even though their incontinence may not be neurogenic. And there are different supplies that are available to use. And I have here some websites that you can look at by the manufacturers of these transanal irrigation supplies. There are small portable ones that involve a handheld bulb, and there are more traditional ones that have a small catheter and an irrigation bag and, a manual pump. So depending on the patient's ability to manage and, if they're using it outside the home, there are a number of options on the market that are available. They may not be available where you are. Some of these I know are available in the UK, but offer some options. Use of transanal irrigation over time has shown to be relatively good. 2 studies show that about half the patients who performed it used it at a year after starting it. And other studies have shown that reasons for discontinuing were either unsatisfactory outcome, problems with performing the procedure. It does require some dexterity and sometimes some assistance, and also complaints that the procedure takes too long. Some patients might report it could take up to an hour of time, and they don't want to have to do that procedure. So another practical strategy is to advise the patient to try and develop regular bowel pattern, and elimination habits often follow. So some of those recommendations would be to eat at consistent times, to eat moderate amounts, to avoid trigger foods, especially when they are eating out of the home, to try and develop a regular work, activity, and sleep schedule. And this will help them to defecate at similar times. And we know that with today in society, schedules are very irregular and can be very hectic. And so helping the patient develop this type of regular life pattern can help regulate their bowel habits. Some patients need education or tips about practical coping strategy. We know from numerous qualitative studies that knowing the location of the nearest public toilet is a common and important coping strategy for individuals with fecal incontinence. There are some online resources. There are some apps that people might be able to use to help them identify these if they are unfamiliar with them. Other advice includes preparing a small kit for cleansing and changing if an accident occurs in public. These can be placed in a purse or if it's a male patient, in a backpack, perhaps, that they might carry. Some patients might benefit with eating light before they go out into public, skipping that meal before they go into public, and maybe eating while they're there because it may take a while for a bowel movement or leakage to occur, or modifying what they eat in public to avoid those trigger foods. Things just like asking for a table that might be near a restroom might be helpful if they have a great sense of urgency, and they can make that request without letting know the reason. Now, absorbent products are part of the plan. They contain the leakage and avoid soiling onto outer clothing, and many patients use them while they are learning and practicing other interventions, such as their pelvic floor muscle exercises. They tend to be used more by women than men, and so men may need some education about these products. There are many types of products that are available on the market, and patients and caregivers often need information to make appropriate selections and about cost effectiveness. Many absorbent products are designed for urinary incontinence rather than fecal incontinence, but patients can use them nonetheless. And there are some resources available for nurses to learn more about these products to educate the patient. There is a Continence Product Advisor website that is available through the International Continence Society. It's free to access and use. And also the WOCN Society in the US had a publication in 2018 about the different types of body-worn products to help educate the nurse who is advising this patient, especially if they are new in the area as a continence nurse. Now, I didn't mention functional incontinence. This is incontinence due to limited mobility, cognitive impairment, environmental barriers, or financial restraints. So there are some practical strategies that can be used to manage functional incontinence. Work on trying to increase the mobility and physical activity of those with mobility problems if possible. Refer them to physical therapy as needed. Reduce environmental barriers, such as having a commode or a urinal that would be closer than a toilet, especially if the toilet might be on the second floor of a home and require climbing stairs. The use of incontinent briefs or pads. We now have external catheters, condom type for males, as well as there are external catheters for females. For those who have dementia, finding clothing that has some modifications that makes it easier to dress and undress. So instead of, fumbling with a belt or a zipper, just pull down pants. For those who have difficulty remembering where the bathroom is with the toilet, having, a picture that they could recognize, or in institutions, some signage that directs them may help them remember. We talked about keeping a regular schedule, and for these patients, adding some time toileting might be assistive for them to regulate their bowel movements. And even pelvic floor muscle exercises can be modified for those who have some mobility problems. It can be done primarily in the sitting position, maybe using a child's medium-sized ball that they can just squeeze between their knees to help with exercising those muscles. So if initial management strategies are not sufficient, there are some secondary interventions that can be tried and added. And these are secondary because the evidence supporting their use to reduce fecal incontinence from studies is not as strong as those for the initial interventions. So there are some devices which can temporarily block fecal leakage from the rectum. They may not be available everywhere. One, there is the anal plug which is made of a soft foam-like material and is inserted like a tampon and expands in the rectum. There's an anal insert that functions similarly to the plug, but has a different design. The inner disc is inserted into the rectum, and the outer disc is outside the rectum. And then there's the vaginal bowel control system that's inserted into the vagina. And when the balloon is inflated, it compresses the rectum closed from the vaginal side to prevent leakage. And of course, this could only be used in women because it is inserted into the vagina. And then there are behavioral therapies, which in Brazil you refer to as rehabilitation. They involve training with a continence specialist clinician, such as a nurse. So biofeedback therapy uses electronic or mechanical devices to amplify or monitor neuromuscular activity, sending patients information using visual or sound signals. So the patient would practice their pelvic floor muscle training or their strengthening of their external anal sphincter, or maybe coordination of the muscles that are used in having a bowel movement. Some need to be relaxed, some need to be contracted. And they would receive feedback, on a computer screen as to how they are doing with these different aspects of their muscle training. Some patients might also need some assistance being aware of the sensation or the urge to defecate, and this can help them progressively be aware of that sensation. Electrical stimulation is another strategy. Electrical stimulation can use a probe that's placed in the anal canal or electrodes on the perineum near the anus or on the tibial nerve. The stimulation is used to enhance the strength or endurance of muscle contraction, helps raise awareness of where the pelvic muscles are, and facilitates, again, the patient performing these exercises and to give them sort of a boost in their contractions. There is a protocol that shows some promise. It's referred to as triple T or 3T, where they combine electrical stimulation of moderate frequency along with biofeedback twice a day. And they felt that that combination of e-stim and biofeedback was better than either one alone. So if we return to our case study of Mr. A, his management plan based on that assessment that we did was that he really could use some teaching about his normal defecation and fecal incontinence. You would ask him to complete a bowel diary and a diet journal during the same week on the same days. He can use this information to assess his leakage pattern and possible trigger foods that might be aggravating his symptoms. It would also serve as a baseline before starting pelvic floor muscle therapy. So because of his weak muscles, he would start pelvic floor muscle therapy. Because of his loose stools and liquid leakage, we would recommend a fiber supplement. And we discovered that his antacid contained magnesium, which can result in some frequency or liquid stools in some people. So we can recommend another type. You would explain absorbent products to him because he complains about soiling of his clothes and the need to do laundry. He says he really doesn't know much about them. And again, providing support and encouragement for him, and to schedule a follow-up appointment in about 6 weeks where you would evaluate his diaries and his progress and his plan and see if any adjustments might need to be made. So I think the take-home messages are that there are numerous initial conservative management interventions that you can use to support patients to help manage their fecal incontinence. Often people think there's nothing that can be done, and these can be effective for reducing their symptoms. It may not cure their incontinence completely, but it may result in enough reduction to meet their needs and goals. And the care plan is based on their assessment, their history, and their needs. And if those initial interventions aren't sufficient, then secondary interventions using rehabilitation can be added. So, obrigado. Thank you very much for your attention. And if you have any questions, I'm very happy to answer them.
Oh, it's great. Thank you so much, Professor Donna Bliss. It's a brilliant lecture. Thank you. Oh, now I think it's open for you, everybody. A question, comments. Oh, Andrea, thank you. Please.
I have one question.
Okay.
Hi, Dr. Bliss. My name is Julia. I'm doing my master, nursing master's. And we know that patients' confidence is very shaken by these dysfunctions, right? So what would you advise us to increase this patient's self-confidence? Like, because when we have these patients in our out hospital appointments, we see we face difficulty in this patient's confidence. And I'd like to know, just wondering if you have any advice.
Some advice would be to ask them what bothers them the most. Like, what do they want to work on first? And you can, assess what their different problems are, as we did in this case. And if you ask them, well, what bothers you the most? And to try and recommend the different interventions, and then to ask them what they think they can do first. So if perhaps keeping a bowel diary and a diet record is something that they might be able to do and, sort of observe their pattern, that may be the first step. And maybe you would ask them to come back sooner than you would someone who maybe is doing another intervention. If they feel they might be able to adjust their diet, if we see some dietary associations, for some individuals that's difficult. So maybe you won't start with that one. Starting pelvic floor muscle exercises, even for very short numbers of repetitions and durations, will get them started. So you wouldn't maybe ask them to try and do 10, but say, let's start with 2 in these different positions, in these times per day. And then they will gain the confidence, oh, I can do 2, 3 times a day. And then when they would come back and say, well, let's increase to 5, working that progressive. So really trying to find out what they think they can do. None of these interventions will be immediate, other than maybe a medication. And if that is something, they need an anti-diarrheal medication of something that is very important to them, you can use that and have them work on the other aspects, because it will take time. I think it is such a distressing problem that patients want the problem immediately fixed. And it is very discouraging when, it's like conditioning any kind of muscle and exercise. It takes time. Dietary changes, even a fiber supplement, do not work immediately, and you wouldn't take a large amount immediately. And so it does take some work over time, and, trying to find something that feels positive for them that they can do, with the idea that this intervention is not necessarily going to result in a complete cure, but helps them gain their confidence and their abilities, their skill building, and then they're coming back and they're building on that, really working toward that skill building, because they are very distressed. And sometimes those practical suggestions while they are working on their other interventions, absorbent products, those kits for change when they are going out, staying near a toilet, they can help in the short run and may become, usual routine as they work on the other strategies.
Yeah, I agree with you. Thank you for explanation. And start with a small to-do list is a good idea. So thank you.
I think you can also show them the list so they don't feel discouraged that the short list is not working. And so if they know this is the start, but there are other things that they will do, and it could be like, okay, we're going to start this, and maybe you can't see them, if they can't come in so often to talk with you, you can give them a time period. Well, for the first few weeks, do this. And if you can do that, then in the next few weeks, increase the amount and keep a record. We are presenting some findings at the WCN conference. We hope to be submitting an abstract with some findings from a recent study that we did, where patients said even though keeping these diaries are kind of a bother, they are very helpful. Then they can have a record of what they are doing, and they can see that it is showing some benefit, because people don't remember. You think about, can you remember something you've done 4 weeks ago? Well, if you have it on a record, that you can go back and say, oh, well, look, I have fewer leakages, or I am practicing, or, this is the number I am at, or these are trigger foods. I have to remember to avoid that one. So writing them down, even in simple forms, they don't need to be very long. You see these forms are recommended to be short and useful, might be helpful to them. So maybe asking them to keep a record and letting them know it's okay if they miss a day or two. They don't have to be perfect, but it really is sort of a tracking, that self-monitoring what's going on, sort of helps empower them, that they feel that they are in control and they have a record. And then they can come back to you and show you, at a usual interval if they can't come frequently.
Oh, that's great. I don't know if Andrea, Victoria, would you like to ask some question or comments, or in Portuguese, and we help you translate to English for Professor Donna Bliss?
I also think these interventions can use more research. So for those of you who are thinking of topics for your master's and dissertation, to look at these interventions, we have some research, but they are in need of additional research. So there is much to do in terms of the evidence, and we can refine our recommendations. And if we find that something isn't beneficial, then we shouldn't be asking patients to do them, and focus on those ones that we think will work. And, I also find sometimes that even though we would like to start with one intervention and see how it works and see if we can add another one, because we can see patients that frequently, sometimes we have to recommend, a couple. Try this and then do this, as we were doing with this case, because we don't have the ability to see them that often. And so we give them a couple of different strategies to work and try at the same time. And so it's difficult to tease out which ones are working. So it's oftentimes a combination of things, because that is the reality of what our clinic visits are these days.
Yes, I agree. Last week, we have this situation in our outpatient clinical, and we need to share, to start the conversation, and after to establish the self-confidence with patient and parents or family. So it's so interesting. Professor Giselle, would you like to have comments?
While Andrea and Victoria are still thinking, I just would like, first of all, to thank you again, Dr. Bliss, for sharing your knowledge and your time with us this morning. We really appreciated your time and all your knowledge. I'm just wondering, because I'm a pediatric urology nurse. And I have recently, now she's doing her PhD, a nurse that works with transanal irrigation for kids with neurogenic bowel dysfunction. I was thinking, in the case of kids, particularly, we have really is quite nothing about the evidence in terms of trigger foods, even for fecal incontinence or even for potentially bladder irritants. What do you think in terms of these populations, especially thinking about kids? I know you're more adult, but I have a nurse who works with us, and she was telling me, well, I don't think that I will teach moms and caregivers to avoid potentially bladder foods, because we don't have evidence and a stronger one to use this as a kind of recommendation based on good evidence. But I told her, well, we are basing in our clinical practice and experience about patients and parents' reports. But what your thoughts about kind of creating a better scene, or making new research questions that could be feasible for us? Because it's hard to do a clinical trial study to avoiding this type of foods, because it's hard, it's quite impossible for us.
It's hard everywhere, I will tell you, but the information, and we were, I think, one of the first to report them, came from descriptive studies. This was something that was known in practice. Clinicians were saying that their patients are doing this, right? They were reporting to them that they were avoiding foods that aggravated their symptoms, and they saw some effectiveness in avoiding their foods. So what we were really doing was documenting what patients were doing. And that is a descriptive study. And other studies with other patients have also supported that. So a descriptive study where you would collect information from parents and children, if they're old enough to tell you, with that association is the first step, because randomized trials need support for investing in the randomized trial, right? They are difficult, they are expensive. And without having some evidence, descriptive evidence of, relational evidence in the literature, there is no even support for doing a trial. It's, as you say, your colleague was saying, there's no evidence. Well, one, I think we need to listen to patients as to say what you are observing. If you see an association, And if you are trying something, often patients are afraid to tell us what they're doing because they think they're doing the wrong thing. And they may get in trouble if, they tell us what they're doing. And if we don't ask, we will not know what they're doing. And so we decided we would ask, and people told us. We had, of the group we interviewed, everyone told us something that, that they were doing. And so we were reporting that. Now, whether it is something that will hold up in a clinical trial is yet to be seen, but it is sort of like, if you think about what some of those supplements and complementary therapies, like if you don't ask, you will not know if patients are taking them. And it will be, regardless of what your treatment plan is, if they are doing this behind the scenes, then they are also doing that. So I think it's better to know and to maybe have it part of the plan. So I think there is a descriptive study that you can reasonably do with your pediatric population. And I think you are right there. It is not my focus, children, but I am not aware of anything in that literature. I think it is also challenging for children because they are just starting to eat various things. Most adults have their dietary patterns down. If you look at diet records, I've looked at numbers of them. It's quite interesting. People eat things in a predictable way. They have what they like and what they eat, and those trends are established. On occasion, if they travel, they might try something new, but everyday people tend to eat, similar things. But children are trying new things and adding new foods depending on their age, and they like things and not. So theirs is, I think, much more variable. So I think it's really interesting to try and see if there are these bladder irritants and trigger foods, or if the parents notice something and then they stop giving it to them. They may be doing that on their own. So I think that is worth a master's study right there from anyone who needs an idea.
Thank you. Yes, I totally agree with your thoughts. Thank you again.
And I have a comment. I'm really happy to join with you again. I don't know if you remember Professor Donna Bliss, but I'm still in nursing school. So a lot of things you share with us today is new to me, but it's great to learn and share this knowledge. And I'm really thank you to you.
Oh, you're welcome. Victoria, we are seeing here in the United States that many WOC nurses are in their middle age, and many of them more approaching retirement. And so it is so important to have new, younger nurses entering this specialty. And so I think it is wonderful that you are interested in this area and also learning about what we know, because as new people come, we have to inform them about what we know, so that they can help us advance the knowledge and the science. So I'm very happy to see that you are interested in this area, because we need you, many of you, to carry on the work that people before us have started.
Yes, of course. I'm glad too, because Victoria, I'm her professor about the research undergraduate, and she likes to study about that, especially patients with elimination stoma. And her project, it's about this diarrhea, sorry, about the diet modification, about these behaviors. How can we help our patients at outpatient clinical? It's so special for me. Hearing you in English, it's so good.
Yes, your English is very good. I think what I have found in talking with patients is they are often managing their problem before they come to us, right? They have a routine and they know some things that work mostly, some things that work sometimes, and some things that have not worked for them. And so starting there and finding out what they are doing, what they feel confident in doing, and what works and what doesn't work, and trying to include that in your plan and build on that, I think is very important. I think it reinforces the engagement of the patient and their self-knowledge. And it recognizes that they come to see us so infrequently compared to their daily life and what they need to do. And I think it acknowledges the importance of the information that they know. Now, not everything is effective. Patients do things that they probably don't need to spend the time doing, but we have found that some of them have very rigid routines that work for them. It's difficult to introduce a new idea sometimes, but they wouldn't be coming to see us if they worked 100%. So, working with that knowledge that what you're doing, okay, but we can improve on that because you are here, right? You need some assistance. And often patients come to us when they can't manage anymore on their own, and they're looking for other strategies. And they likely don't know all the strategies. I mean, we have found that out. Patients really don't know the different options that they can do. But we don't want to totally take away those things that they find useful for themselves. So how did we find out about those coping strategies? We found out from patients what they are doing. And so acknowledging that and including that in the plan, that we are, this is working for you, this is part of our plan, I think is very helpful for them.
Or
Yes.
reduce the negative coping strategies like smoking or drinking, because the mental health, we have patients with I don't know, lower mental health from the dysfunction. So to improve the positive coping strategies is a good way.
Yes, adding something to do versus not to do is a much more positive approach. And Lais, you are working on, recent ideas, strengths-based interventions have that similar idea, right? Work with someone's strengths versus their deficits. Sometimes you need both, but starting out with a positive, you can do something, and we'll work on what you can do is always a good start. And then later on, you might be able to introduce removing things. And with fecal incontinence, the association with smoking cessation is not been established. So maybe working on the fecal incontinence first, and then work on the smoking cessation afterward because of general health, right? In the past, fecal incontinence was primarily considered a symptom of other health problems. And so the focus was on working on those other health problems and not so much focusing on fecal incontinence. And you really need both, right? A healthy person will have a good response, and having a focus specifically on the fecal incontinence can also help.
Yes, I agree totally. Yes. Oh, it's a good conversation. This is a special time. Unfortunately, we some late,
There are
but
time.
I I thank you, Professor Donna.
Thank you so much. I would be very happy to learn at some point in the future of all your projects and your achievements when you are finishing them. And I hope you will send them to me. And good luck, ladies, in your Canadian study. And so nice to see you all again.
Oh,
Nice to
thank
meet
you.
you, Professor Giselle. I'm very happy to meet you, even by
Me too.
some
Yeah, me too.
maybe in person.
Yeah, always good for us that enjoy this area. Hopefully, we'll have more and more nurses and undergrads that they want to work on urology or even in WOC and nursing, right?
Yes, yes.
We are really happy.
Thank you all so much.
Bye.
Thank you. Thank you. Bye-bye.
Thank
Have a
you.
great
Bye
day,
bye.
everybody. Bye-bye.
Thank you, Laís. Bye-bye.